here is your question. Nothing to read, okay? I just didn't realize it wasn't updated. So the pictures that I have to show you in this one are still relevant to the topic that you have chosen. So we'll discuss this. Right. So if you have read and understood, considering it surgical augmentation,
Yes.
kindly tell me if you can identify all the structures from A to F, please.
Yes.
First
A
of all,
is the
tell me what are you looking at?
yes. This A is internal carotid artery.
Yes.
And
before that, what kind of image is this, please?
this is the arteriogram, cerebral arteriogram, angiogram. We can
Cerebral angiogram.
say
Yes.
arteriogram.
Okay.
Angiogram,
Yes. What is A, please?
A is internal carotid artery, and C is anterior. B is anterior communicating artery, cerebral, and E is the anterior cerebral artery, and D is the middle cerebral artery, and F is the posterior cerebral artery, and posterior communicating artery, and E is basilar.
Okay. All right. Why? What are the indications for asking for carotid angiogram or cerebral angiogram?
If there is a patient with a stroke or hemorrhage, intracerebral hemorrhage, or TIA cases, then we will do the cerebral angiogram.
Okay. Does it have any significance in space occupying lesion cases?
Yes, space occupying lesion, yes.
As well. Okay. So now you've told me all this. Very good. Can you please tell me how the circle of Willis is formed?
And circulus Willis is communication between the anastomosis between internal carotid artery and the vertebral artery, and vertebral artery enter in the foramen magnum to make the basilar artery. Basilar artery there are many branches, but the main branches of circular Willis is the posterior cerebral artery. Now the internal carotid arteries branch the posterior communicating artery, which join the posterior cerebral artery. The internal carotid artery gives many branches like middle cerebral artery, but the most important is the anterior cerebral artery, which join with the other anterior cerebral artery by the anterior communicating artery. So this circular Willis is formed around the optic chiasma and the pituitary gland to give blood supply, communicating blood supply to the corpus striatum, cerebrum, and midbrain and pons.
All right. Good. Can you please
Madam,
tell
your voice
me,
is not
isn't it? Oh, yes, it must be internet. Can you please tell me this arrow is pointing at something? Can you identify what is it?
Yes, this is the yes.
Yes.
This is the aneurysm, Barry aneurysm.
Of yes. What is the other name of this Barry aneurysm? Middle.
It is, I think it is middle cerebral artery.
Yes.
Junction to another artery branches.
Yes, it's the aneurysm of that is what. Okay, in a patient which presents with Barry aneurysm, also at the same time presents with another condition in the body. What is that?
Yes, there are many cystic diseases like polycystic kidney.
Yes. Okay.
And
can you please tell?
Liver.
Yes, thank you. Can you please tell me the supply or the area of supply of vertebral artery? Vertebral artery supplies which
Yes.
area
Vertebral
of the brain?
Vertebral artery gives posterior inferior cerebellar artery. So it gives the blood supply to the cerebellum, and it also gives branches to the medulla oblongata, and these are
Does
the two
it
main
give any
branches.
branch when it enters the skull through foramen magnum?
Yes, it gives when enter into the skull, it gives posterior inferior cerebellar artery, anterior spinal artery, posterior spinal artery, and make basilar artery.
Then
So branch is posterior cerebellar, which is given to the cerebellum.
okay, this carotid artery, it gives
And
one
then
branch.
it also supply the
Can you please tell me the branch which is given before this internal carotid artery? It enters the skull, and before it gives off the branch of ACA and MCA. What is the name of the branch which it gives out?
your
Is my voice still?
madam, your voice is interrupted, but it is the ophthalmic artery.
Yes,
Ophthalmic artery
it's
before it
ophthalmic.
enters.
Okay,
Yes.
I'll after your
Ophthalmic
revision, I'll
artery.
change. Okay,
Ophthalmic artery.
can you please tell me what are the consequences if this? What is the consequences of knowing about the aneurysm? This aneurysm that you told me. What can happen?
This aneurysm this
May rupture?
due to tunica media weakness, aneurysm form at the junction and it rupture into subarachnoid space hemorrhage, and it can cause pressure on the brain also.
Okay,
These are the two
can
things.
you please tell me some signs of
May rupture
middle
in the subarachnoid space
yes,
and
MCA
may cause
infarct? Yes.
pressure symptoms on the brain tissue.
Sorry, my network.
Just network.
I'm sorry, network is, I'll change.
No problem, madam.
Second. Okay, can you please tell me the
Ye-
signs? When there is infarct of middle cerebral artery, what are the signs that you'll see or you'll find? Please.
Yes. Yes, madam. That is the hemiplegia contralateral to the face and to the right upper and upper and lower part of the body. And there is aphasia. Aphasia.
Good. Okay. Right.
These are the
Can you please tell me at what level common carotid artery bifurcates?
common carotid artery bifurcate at the upper level of the thyroid cartilage into internal and external carotid artery. And level, I think it is T4 level. I think so. T4.
Can you please tell me what kind of image is this one?
Yes, this is the cerebral angiogram.
Okay, can you identify there is one arrow
Yes.
here? This I tried to hide, but still it is.
Yes, madam.
visible.
The lower one arrow show
Yes, this one.
a middle carotid artery. Middle carotid,
No,
middle
internal
carotid artery branch.
This- And here is the question. Right. So if you have read and understood, considering a clinical examination station, kindly begin, please.
I'll enter the room. I'll
Yes.
greet the examiners and I'll greet the patient, and then
Yes.
I'll wash my hands,
Yes.
and then I will
What is your
uh,
examination number?
my candidate number is 3091.
Yes. Okay. Now, patient. Yes.
Hello, I'm one of the exam candidates. May I confirm your name and age, please?
Tina, 32 years old.
Hello, Gina. Nice to meet you. Today I have been asked to examine your this swelling which is present in your neck, and this
Not
will
neck.
involve
Not neck. Under the jaw.
under the jaw, and this will involve looking, feeling of your swelling, and also the examination of the various glands in your neck. Is that okay with you?
Yes.
Okay. So do you have pain anywhere over your swelling?
Yes.
Okay. So now I'm going to have a close look
Okay.
over
You
your.
asked for the pain and then you'll offer. Do you need the analgesics or is that okay? We can continue with the examination.
Okay. Okay.
Right? Okay. Now, what would be the position of the patient and the
Patient
exposure? Tell me, please.
patient will be sitting on the chair,
Yes.
and with the collar down of the with the collar down of the collar down. Yes, or maybe
Okay.
we can ask him to open the upper two buttons
Her.
of the shirt.
Yes. Yes.
Often yeah, upper two button of her shirt.
Yes.
So of while now I'm going to have a close look. So on inspection, I would see I would like to see the size, side, shape, overlying skin, overlying skin surface, or any scar or sinus on the swelling. And then on the opposite side, is there any swelling present or not? And then on inspection, I will ask, can you please show me your teeth?
Okay.
And then I will ask about the hypoglossal nerve. Can you please stick out your tongue for me?
Yes.
And can you please touch your cheek with your tongue, and now push against my hand, first on the
Okay.
right side, then on the left side.
Yes.
Now I'm going to look inside your mouth. Can you please open your mouth for me?
Yes.
And then stick up your tongue for me. Here I will see the opening up of the some mandibular ducts on either side of lingual frenulum, whether there is any inflammation, or the saliva is clear or not, any discharge is present or not, or is there any swelling in the floor of the mouth. Now I'll be moving on to the palpation part. So would you mind if I examine you from the back?
Okay.
So now first on the palpation, I will look for the temperature, tenderness of over the swelling, and its fixity to underlying structures, its fixity to edges, margins, surface, compressibility, reducibility, pulsatility.
Good. Yes.
And then after that, I will then feel the various lymph nodes in the neck, which will include submental, submandibular, anterior cervical, posterior cervical, preauricular, posterior auricular, and supraclavicular lymph nodes, and posterior and occipital lymph nodes also. And then I would like to examine the oral cavity. I would like to do the bimanual test. I would
Yes.
like to examine. I would like to
How
feel
would
the
you do
swelling.
that? Yes.
I will
You'll put the gloves on.
I will gloves on. Yeah, I will
Yeah.
wear the gloves,
Yeah.
and then I will say I will like to feel the swelling from inside the mouth.
Yes. And
I'll gain consent.
if it hurts you or it becomes here painful, then you'll give
Okay,
the
ma'am.
instruction that patient will tell you and you'll stop. Yes.
Okay, ma'am. So if it hurts you, then just let me know. I will stop. So
Okay.
then I will put two fingers on the floor of the mouth,
Index
and
and
then
middle finger.
index and
Yes.
middle finger,
And
and then from the other hand,
yes.
outside the swelling, I will feel for the lobe,
Yes.
deep lobe of the swelling, or
And
then and the duct, some mandibular duct.
yes.
Is there any
Duct.
calculus present or not?
Yes.
And also I will feel for the opposite side.
Yes.
And then on the tongue, I will feel for the lingual sensations. Can you feel my finger over your tongue?
Okay. Yes.
That's a lingual now, and then I will thanks the patient. Then I will thanks the patient.
Okay.
So that's complete my examination.
Yeah, you'll do the same on the other side as well. Okay. 2 seconds are left. Okay, start. Can you please present your examination?
Um, uh, Tina, 32-year-old female, presented to me with the swelling in the over her below her right jaw. And on
Yes.
inspection, the swelling is present in the right submandibular area, which is oval in shape, and there is no overlying skin. Overlying skin is normal, and there is no
Oval
previous
in
scar
shape
sinus.
and size? How much in diameter?
Size approximates 2 into 1 centimeter or 3
Okay.
into 1.
Yes.
Size of approx 1 centimeter, and on palpation there is a tenderness present over the swelling.
Okay.
The local temperature is not raised. There is
Yes.
the swelling is nodular swelling. The
Yes.
edges are well defined edges.
Yes.
It is fixed to underlying structures,
Okay.
and
Yes, you
overlying
still have
skin
time. Yes.
overlying skin is not fixed,
Okay.
and
Any lymph
the,
adenopathy?
there is no lymphadenopathy.
Okay.
There
So
is
what are your provisional and differential diagnosis, please?
So provisional differential, there could be a submandibular cellulithiasis,
Yes.
or there could be submandibular neoplasm.
And could even be dental infection.
Yes.
Okay. How would you confirm your investigation? How would you confirm your condition?
First of all, I would like to go for the ultrasonography of the swelling, and then X-ray. X-ray, if I'm looking for any calculus, then cyelogram if I'm looking for any calculus, CT,
Okay.
and
And considering your third diagnosis or
neoplasm, then I will go
yeah,
for the
FNA.
FNAC. FNAC.
Okay. So what are the treatment options that you can offer to this patient?
First of all, I would like to offer her conservative management, which will involve the good oral hygiene
Yes.
and antibiotics,
Yes.
anti-inflammatory, and
Yes.
the oral massage, and the massage over the gland.
Yes.
And then the surgical treatment will involve the salendoscopy, cyelogram, which is act as a therapeutic as well as a diagnostic.
Very
It
good.
helps to wash out the calculus from the duct.
Yes.
And we can also offer her the endoscopic removal of the stone. And then in the last, if I'm expecting neoplasm, we can go for the submandibular gland excision.
Yes, very good. Okay. 2 seconds. Very nice. Good. Nothing you left behind to discuss. It was small things that you were missing. I told you in the way.
Yes, ma'am.
So it was covered. Started your timer, and here is your question. Right. So if you have read and understood, considering its communication skills station, kindly begin.
I will enter the room, wash my hand, greet the patient. Hello, how are you today, Mr. John? How are you?
Yeah, I'm fine.
Okay, I'm Dr. Muhammad, one of the surgical doctor. And today I would like to speak to you. I'm just told that by the nurse that you have concern regarding taking your pills called the warfarin. Could we please have a seat, please? May I just
Yeah,
give you a hand?
thank you.
Thank you. Yes, can I confirm your name and age?
I'm John. I'm 65-year-old.
Okay, nice to meet you. So, as I mentioned, I just been told by the nurse that you have some concern regarding taking your pills. Is that all right?
Yeah, doctor.
Okay, can you please tell me what is your worst, your concern about this?
Yeah, doctor, do you know that I have underwent mechanical heart valve transplantation a few years back, and my
Mhm.
doctor has given me a warfarin tablet, and he told me not to uh, omit it ever. But now that I am having this hernia operation, doctor told me to
Mhm.
stop it. So I'm little worried if it affect
Uh,
my heart valve.
yeah, I appreciate your concern, Mr. John, but let me take it from here. Okay, you just have been described this medication because you have some artificial heart valve, and this medication actually prevent the formation of the clots in your heart valve. Is that right?
Yeah.
Yes. So as we are going to operate on you, so this medication actually act is thinning the blood, so there will be more bleeding because, as I mentioned, it prevent the formation of the blood, so there will be thinning in your blood. So as we are going to operate on you, we have to avoid this bleeding, which may be going inside the surgery and even after perform this surgery. That's why we need to stop this medication. Are you following me, Mr. John?
Yeah, doctor. Please go on.
Yes. Actually, we need to stop this medication just 5 days before the operations because it has a long duration of action. Okay?
Okay.
But you don't have to worry about this. We will not leave you without any protections. We are going to give you another medication. It's called heparin.
Mhm.
Have I addressed your concern?
But doctor, this are these both drug works in the same way?
That's a good question, actually. This new medication is called heparin actually has the same action of your old pills, which is the warfarin. The difference is warfarin, this has a long duration of actions, take about 5 days, while this actually heparins act only for 12 hours. So we will just stop it 12 hours before you go for the surgery. Okay, that's why we need to stop this warfarin because it has a long duration of action. We have to stop it just 5 days. This is the difference. Am I making
So,
myself clear?
so are those two medicine the efficacy is the same? They work in same way?
It is have the same effect actually in thinning your clot and prevent the formation of clot in your artificial valve. Yeah, but as I mentioned, the difference is in the duration of the actions. This is
How
a
is
new medication. Yeah, yes, please.
how is this supplement be given to me?
Yes, we are going to, this will be actually injectable. So you just might have some pain because of this injection. So you will not take a tabs as you are just took it like the warfarin one.
Do I have to
So
get
we need
admitted
to give you
to
this
hospital?
medication. Sorry.
Do I have to get admitted to hospital for this medicine heparin injection?
Actually, I appreciate your concern. I will offer you two options here. Either you can stay at the hospital during the 5 days and you will receive this medication by injection. And I just recommended you just to stay at the hospital just to observe you if something bad happened to you.
Sorry, I didn't follow you.
You actually have will offer you two options. You can stay at the hospital and for during these 5 days because this is
Okay.
this medication you will just receive this through injection. So
Okay.
you just get the chance we can observe you. until the date of your surgery. Another option, if you are preferring to go home, then I can arrange with a special nurse just to give you this medication at home. Which one you are going for, John?
Yeah, I would prefer to stay home.
Okay, okay, I will go into just speak to the nurse and the social worker just to provide you a nurse at home. Does
How
that
long are
sound
you-
make?
Yeah,
Yes.
that sounds good. That sounds perfect. So how long are you going to continue this heparin?
That's a good question, actually. After you perform the surgery and to make sure that there is no bleeding after the surgery, then you will keep giving you this medication, the heparin, and then we are going to do some blood tests until we make. And meanwhile, also you will receive the warfarin one, which is the old pills. So we will give you these medications simultaneously. And meanwhile, we're going to do some blood tests just to make sure that warfarin has regained its function. At this point, then we are going just to stop using the heparin one, which is the injectable one. And so you can go taking your old pills as usual. Am I making myself clear?
Yeah, so I have another question, doctor.
Yes, please.
My surgeon said that I have to keep my INR that I do every month within 2 to 3. So how are you going to maintain this INR with heparin? Or how are you going to monitor it?
Yes. So as I mentioned, you are going to do some blood test for this just to make sure that you were the normal range that you have just mentioned. So just to prevent any further bleeding that before the surgery and even after the surgery.
So are you going to test my INR during this heparin injection?
Yes, we are going to just monitoring that. This we're going to do this blood test after your surgery.
Okay. So can I take any sleeping pills during sleep or before the operation?
But just I have one question. Why are you taking this sleep medication?
Yeah, my doctor suggested me if I can't get an adequate sleep to take this sleeping pill.
Okay. You are going to just take your old pills before going to the surgery, but if you are going to take this medication at the morning, just take it with the only sips amount of water. Okay.
Okay.
Do you have any further questions? Anything you'd like to tell me? Okay.
No,
Can you just please summarize for me what we have went through, just to make
One
sure
more-
that
one
you
more-
have?
Can I ask one more question?
Yes, please.
Is there any additional risk of administering this heparin instead of warfarin? Because I am used to this warfarin. Now, all on a sudden, if you start heparin, will there be any risk?
Up to my knowledge, actually, I don't think there is more risk because of this medication. But I will just contact my consultant and also just to ask him about this, and then I will tell you. Okay.
Okay, that makes sense. Okay.
Do you have anything you'd like to tell me? I'm willing to listen.
No, it's okay.
Okay. Can you just summarize for me what we have went through, just to make sure that you have I addressed your concern?
Yeah, you have told me about this, that my warfarin should be discontinued for 5 days prior to my surgery, and you will start heparin, which should be given injectable route, and I prefer to take it in my home. So you are going to arrange some social services or nurses?
Perfect, actually. That's what
And
you
you
are
are going,
going. Yeah. Yes,
and
that's what's
you are
going
going
to be
to
happening.
restart. Yeah, you're going to restart this warfarin after my surgery, right?
Yes, exactly. So we are all here just to support you and have you and give you a hand at any time. If you have any further questions, please don't hesitate to contact me. I will leave my phone number with the nurse. Thank you so much for your understanding and have a nice day. Thank you.
Yeah. Thank you,
Your
ma'am.
question. Okay, so if you have read and understood considering this communication skill station, kindly begin.
Okay. Hello. Good morning, sir.
Hello, good morning.
I am Muhammad, one of the surgical house officer working in Mr. Man in Ox Hospital. I am calling to speak to Mr. Jatin, ask a hepatobiliary consultant on call to ask him advice about the patient underwent laparoscopic cholecystectomy. Could I check that I am speaking to Jatin, ask a hepatobiliary consultant on call?
Yes. Yes. Can you please summarize your case?
Good.
Okay. My patient, 44 years old, obese female, underwent laparoscopic cholecystectomy 4 days ago. Now complain of worsening abdominal pain, nausea, on examination, and also tachycardia. And the investigation, total total leukocyte count 80, and CRP 15, and the bilirubin high, and free fluid in the abdomen, and no CBD dilatation. After that, I resuscitated the patient, and I hoping to transfer the patient to hepatobiliary consultant for definitive treatment.
Okay. So what are the possible sources of the biliary leakage? Do you know?
Yes, sir. Maybe cystic duct stump leakage, maybe common bile duct injury, and maybe leakage from the accessory duct, and maybe leakage from the liver bed.
Okay. So what will be your management in this case?
Yeah, the management as acute critical elevation crisp protocol, ABCD approach. After that, I will start with the fluid resuscitation and monitoring the patient. And after that, I will put the patient on antibiotic according to culture and sensitivity after a discussion with microbiologist. And then I will order repeated investigation when I am off the phone. After that, I need to do ERCP. The patient need transfer because the ERCP not available in this hospital for identify the source of leakage and for the treatment.
Do you have time for the culture?
What's here?
Do you have time for to send the culture and wait for the report and then start antibiotics for this patient?
No, sir, because the patient is urgent. I will follow the hospital local policy. After that, the patient need urgent intervention to avoid biliary peritonitis for this patient.
Okay. Okay. So do you need to arrange with anyone?
Yeah, I will need the with manager of the hospital to discuss creating whether by facilitated discharge or repatriation of the patient because the patient need early transfer to other hospital.
Okay. Ma'am, these are the only questions.
Ask more.
Yeah.
Expand. Ask more questions.
Okay, so can you please explain me what ERCP stands for?
Yeah, this is endoscopic retrograde cholangiopancreatography. This is X-ray introduced of the telescope inside the mouth and then stomach and then the duodenum. Injected of the contrast to look inside common bile duct and the pancreatic duct and the gallbladder. This is X-ray. ERCP, this is diagnostic and the therapeutic to detect the site of leakage and detect any missing stone, and for the treatment as stent and sphincterotomy and relief pressure.
Why is it better than MRCP?
Yeah, this is invasive, diagnostic, and therapeutic, and the MRCP just diagnostic, not the therapeutic.
Good. Ask more.
Okay,
What,
so
ma'am?
You still have
Why do you
3 minutes.
think the bilirubin is raised?
Yeah, I think the bilirubin raised could be common bile duct injury and could be common bile duct stone leads to obstruction of the bile because of the maybe CBD injury or stone in the pancreatic duct, reflex of the bile in the gallbladder leads to increase bilirubin.
can you please tell me what are the various types of gallstones?
Yeah, pigment stone and cholesterol stone.
Good. Which ones
Okay.
are more common?
Yes.
Yeah, cholesterol stone more common because of the increase hypercholesterolemia, and the pigment stone maybe seen in patient of the hemolysis or post bypass surgery or after weight loss surgery.
Okay. Just suppose I don't have a bed available right now. How long can you keep the patient to yourself, or how long patient can wait?
Yeah, I will monitor the patient, start with resuscitation, and monitor the patient hourly. And I will contact with bed manager to urgency to transfer the patient for incidence of the facilitate discharge or rehabilitation of the patient.
How do you plan to transfer the patient? Who would
Yeah, according to
accompany the
the
patient? Yes.
yeah, first company with anesthesia and the IT registrar, and I will need the resuscitation kits as intubation and more IV fluid and blood transfusion, and also the situation and the distance of the another hospital. If the near, I will transfer the patient in the blue light car. If the away, maybe transfer the patient air ambulance as a helicopter.
Okay. Would you be accompanying the patient while transfer or not?
Yeah, company. Yeah, I will combine with me and the IT registrar and the anesthetist.
Okay. Any last question you want to ask, consultant? Can you summarize everything you have discussed now? In 30
Okay,
seconds?
for my patient 44 years old, female, underwent laparoscopic cholecystectomy, post-operative. There is complaint of the abdominal pain, nausea, and the tachycardia. Now I will give the patient fluid resuscitation, crystalloid, and monitoring the patient, and repeated the investigation when I am off the phone, and prepare the patient for the transfer and also monitoring and accompany with ICU and the IT registrar. If the anything abnormal or any bad sign, I will contact you again, sir.
Good. Thank you. You can send the patient over.
Thank you, ma'am.
Started, and here is your question.
Okay, I got it.
Yes.
Starts now.
Right. So if you have read and understood, considering it communication skill station, kindly begin.
Okay, I'll enter the station. I'll wash my hands. I'll pick up the phone and call. Good
Okay.
evening.
Hello.
Okay, I'm Dr. Kolade, one of the surgical doctor under Dr. Man.
Yes,
want to-
I am. Yes, I am Dr. Man.
Okay, I want to confirm that I'm talking to Dr. Man. Okay, thank you. I'm calling you in respect of one of our patients. I want to seek advice and discuss the patient with you. So we
Oh.
have,
Yes, please first tell me who is your consultant
Mr.
of
Man.
this case. Mr. Man. Yes, I am Dr. Howard, consultant on call.
All right, thank
Please
you.
summarize your case.
Okay, we have a 69-year-old woman who is a first day post elective right hemicolectomy for Sika tumor. And she also had intraoperative biopsy done for the suspected metastasis. She's having persistent tachycardia and hypotension, and then also has paresthesia. The hemoglobin dropped from 12 to 10 post-operative, though she received 2 units of blood intra-op. The urea and creatinine are marginally elevated. The chest X-ray is fine. The ECG also is normal. Our abdomen is lax and no tenderness. However, our urine output is 10 to 20 ml per hour in the last 8 hours. And she has only received 1,100 ml of normal saline in the last 24 hours post-op.
Okay, please tell me, what do you think about the cause of this problem to this patient?
Yes, I think the patient is dehydrated. She hasn't received enough fluid in the last 24 hours.
Do you think it is dehydrated? Do you think that there is some leakage?
Yes, I think it's dehydration because patient has only received just 1,100 ml of normal saline in the last 24 hours. Though bleeding is also a possibility, but she received 2 units of blood transfused intra-op. Her abdomen is soft, so I won't be suspecting any intra-abdominal leak, and the dressing also is not soaked.
Okay, you are right. If the abdomen is soft, there is less chances of leakage. So what is your plan of action to manage this case?
Okay, my plan of action to manage this case is to give the patient fluid resuscitation. I want to give him 1 liter of fluid over the next 30 minutes. Then monitor his urine output and monitor his other clinical vital signs. Then I will continue to monitor him, serially monitor his abdomen also as well to be sure that there is no leakage in the abdomen.
Did you check his urethral catheter? Is it blocked or not?
Yes, urethral catheter is not blocked. I checked.
Okay. And what do you think about the bleeding in this case? Maybe it is due to bleeding.
Yes, to rule out, though I won't be suspecting bleeding first because the abdomen is soft, but to rule it out completely, I will order for an intra-abdominal, for an abdominopelvic ultrasound so as to see if there's any blood collecting in the abdomen.
Did you, did you perform the ultrasound in this case?
I will order for the ultrasound after the call to rule out any abdominal collection.
And you have already told me that abdomen is soft, so there is less chances of anastomotic leakage. Do you think that I should come back and see this case? I'm busy at the time.
No, I will resuscitate the patient and then monitor him and then give you feedback later, update you subsequently about his improvement or his clinical status.
Okay, okay. 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 At that time, there is no need to summarize the case.
Okay, all right, thank you. So
Yes,
I will do
thank
what
you.
3
I get
minutes.
3 minutes. I can ask some questions about
Yes,
this.
ask, please.
Yes, ask. What do you think that if there is a bleeding, which vessel can be bleeded in this case, in right hemicolectomy?
Okay, if there is bleeding in this case, there could be bleeding from the ileocholic vessel. There can be a bleeding from it, and there can be also be injury to some iliac vessels in the mesentery can also be injured that were not identified. Those ones.
Okay. Maybe there is coagulation profile disturbance and that you will dissect the colon and it can cause bleeding. And because patient has suspected metastasis, maybe coagulation profile may be disturbed.
Yes, that's also a possibility. Patient is also at risk of bleeding diastasis because of the because of the malignancy.
Yeah. And what is your plan about liver metastasis? What is your protocol if there is liver metastasis in CA tumor?
Okay, if there is liver metastasis, I will discuss the patient in the multidisciplinary team so that we'll be able to discuss on what next of action that we're going to do for the patient. But for the liver metastasis, patients can benefit from both. If it is a solitary tumor, can benefit from hepatectomy of the involved segment of the liver, and then chemotherapy also can help to meet the liver metastasis.
Okay, and tell me where will you manage this case until I do not come?
Okay, I'll transfer the patient to the high dependency unit so that patient will be adequately monitored because of his present condition.
Okay, and if there is a major vessel is bleeding, then what will be your plan of action? If there is maybe superior mesenteric artery is bleeding, and how will you diagnose it and how will you manage this case if the BP is going down?
Yes,
and I will.
If it's a major bleeding and I will want to do a rapid abdomen pelvic ultrasound. If there is free flowing fluid inside the abdomen, patients will be planned for an emergency laparotomy so as to be able to secure the bleeding.
Okay, then I have to come in this case in emergency.
Yes.
Yes. And okay, that's all.
Okay, can you comment on the renal function test of this patient?
Okay, the renal function test, the urea is elevated and then the creatinine is marginally elevated.
Yes, that signifies what?
Yes, that signifies in this particular patient signifies slight pre-renal failure, which I will
not failure, insufficiency.
Insufficiency.
Okay, can you, if you look at the urine output, it has been 10 to 20 ml per hour in last 8 hours. So what is the normal average urine output? How much it should have been?
Yes, normal urine output in adults should be 30 ml per hour or 0.5 to 1 ml per kg per hour.
Okay, good. In an average adult, good. Okay, and urea is also showing dehydration, by the way. Okay, good. Thank you.
Thank you, ma'am.